हेलो एवरीवन और आज के इस हाई यील्ड सेशन में आपका स्वागत है। वेलकम टू दिस मास्टर क्लास ऑन सर्जिकल ड्रेन्स, नॉट्स एंड सूचर्स। देखो दोस्तों, whether you're prepping for NEET PG or you're just stepping into your surgical rotation, this is the absolute bread and butter of surgery. We're going to simplify everything, lock in those core concepts and guarantee you some direct exam marks today. बिना टाइम वेस्ट किए चलो सीधा शुरू करते हैं।
फटाफट सिलेबस देख लेते हैं आज का। We'll cover Section 1 on surgical drains, Section 2 on knots and techniques, Section 3 will be suturing principles and needles, Section 4 is suture classification, Section 5 is high-yield sutures and uses, and finally, Section 6 covers anastomosis and suture removal.
Alright, starting off with Section 1, Surgical Drains Explained.
Okay, let's compare two very common closed negative pressure drains. Both do a similar job, लेकिन difference क्या है? Well, look at the Romovac. It has a rounded tube. अगर आप इसको abdomen में use करोगे, there's a huge risk of bowel perforation. इसीलिए, for the abdomen, we almost always use a Jackson-Pratt drain because its tubes are flat and much, much safer. सीधा question आता है exam में, which drain is avoided in the abdomen? The answer is Romovac. याद रखना.
Now, what about specific situational drains? The minivac drain is classically used after a sentinel lymph node biopsy. Chota surgery hai, to chota drain use karte hain. And then think about the underwater seal bag used for chest tubes. Iska simple safunda hai. The tube is submerged underwater so that air literally cannot be sucked backward into the chest cavity. It allows air to go out but not come back in. It's a one-way street.
Moving right along to Section 2, surgical knots and techniques.
सर्जन बनना है ना तो नॉटिंग तो आनी ही चाहिए, राइट? लेट्स कंपेयर द स्क्वायर और रीफ knot with the granny knot. Notice how in a reef knot the thread crossings are exactly the same, black over pink both times. This makes it sit flat and it is incredibly secure. But in a granny knot the crossings are opposite. What happens then? It essentially forms a slip knot that just slides wide open under tension. Proper reef knot आना चाहिए, granny knot की सर्जरी में कोई जगह नहीं है.
Now for even more security, especially in tissues with a lot of tension, we rely on the surgeon's knot. It's just a super simple two-step process. Step 1, you make 2 throws initially, which really locks down that tension. And step 2, you follow it up with a single throw just to secure it in place. So 2 throws, then 1 throw. Simple but extremely effective.
All right, Section 3, suturing principles and needles. Let's talk about the exact mathematics of a perfect stitch. To get beautiful, clean healing, your skin edges must be averted. मतलब थोड़ा बाहर की तरफ निकले हुए होने चाहिए. Always enter the skin at exactly 90 degrees. And here is the golden ratio you need to remember. If your needle bite on each side of the wound is a distance of x, then the distance between 2 consecutive sutures must be 2x. Follow this rule and you'll avoid tissue ischemia and nasty scars. Of course, before we stitch, we need to completely understand our tool. A surgical needle has 3 main parts: the point, the body, and right at the back, the swaged end. What exactly is the swaged end? That's simply where the suture thread is permanently attached to the needle itself. And a pro tip here, notice where the needle holder grips the needle. It should be exactly 1/3 of the distance from the swaged end, not in the middle and definitely not at the tip. Exactly 1/3 from the back. So the crucial clinical point is knowing exactly which needle to use where. एक classic mnemonic pearl देता हूँ आपको. Round body needles simply split the tissue. They are atraumatic. Use them for the delicate B's, bowel, bladder, and blood vessels. Cutting needles, on the other hand, literally cut through the tissue. They are traumatic but totally necessary for tough structures. So use them for the tough S's, skin and sheath. B for bowel, S for skin. Never forget this.
Next up is Section 4, Classification of Suture Materials.
Guys, you need to mark this table as a guaranteed image-based exam question. You have to be able to identify sutures just by their color when you're in the OR. Brown is catgut, violet is vicryl, blue is proline, and black is silk. I highly suggest you pause for a second, take a mental screenshot of this, and lock it in your memory. सीधा exam में पूछा जाएगा ये. Let's classify these threads fundamentally. Natural sutures, like silk and catgut, are recognized by the body as foreign objects, so they mount a pretty strong inflammatory reaction in the tissue. If they are the absorbable type, they dissolve by enzymatic proteolysis. Synthetic sutures, like proline and vicryl, on the other hand, are mostly inert. They cause very minimal tissue inflammation, and when synthetic absorbable sutures break down, they do it purely by water, a process called hydrolysis. This is a very core pathology concept directly applied to surgery. Another really important way to look at them is monofilament versus braided. Monofilaments, like proline, are just single strands. Because of this, they have a strong memory, meaning they constantly want to spring back to their original shape. This makes them difficult to handle and means you need to tie more knots. Braided sutures, like Vicryl or silk, are woven together. They handle beautifully, almost like a soft cotton thread. But because of those tiny microscopic gaps in the braid, bacteria can actually hide there. So braided means an increased risk of infection. It's always a surgical trade-off.
Moving on to Section 5, high-yield sutures and their specific uses. First up is our daily driver, Vicryl, chemically known as polyglactin. It is a braided, synthetic, absorbable suture. It typically dissolves completely in about 60 to 90 days. Because it's absorbable, we can safely use it inside the body, perfect for the common bile duct, the bowel, and the bladder. Oh, and a special high-yield note, Vicryl Plus is actually coated with an antibiotic called triclosan. Why? To counter that exact braided infection risk we literally just talked about.
Next is proline. Remember the color? Blue. It's a synthetic, monofilament, and totally non-absorbable. We use it when we need absolute permanent strength, things like fixing a hernia mesh or doing vascular repairs. Now, for abdominal wall closures, you must pay close attention to Jenkins' rule. The length of the suture thread you use must be greater than or equal to 4 times the length of the actual wound. Agar wound 10 centimeters, hey, then you need at least 40 centimeters of proline. This is an absolute must-know concept for any aspiring surgical resident.
And finally, Section 6, anastomosis and suture removal.
So you've put the sutures in beautifully, but now, when do they come out? This timeline is super high yield. The general rule of thumb is based entirely on local blood supply and cosmetic importance. Face sutures come out the earliest, in just 3 to 5 days, to prevent those ugly track marks. The scalp and neck take about 5 to 7 days. The thorax and perineum take 10 to 12 days, and the abdomen, which is usually under a lot of structural tension, requires a full 12 to 14 days before you can safely remove them.
This brings us perfectly to bowel anastomosis. Look at this classic 2-layer repair. You have a critical inner layer called the Albert layer. This goes through all the tissue layers and uses a continuous, absorbable suture. Then, covering that, you have an outer layer, the Lambert layer, which is seromuscular, interrupted, and usually utilizes a non-absorbable thread like silk. So just remember, inner Albert, outer Lambert.
Now, remember how skin sutures needed everted edges? Well, the bowel is the exact opposite. Bowel anastomosis requires inverted edges so that the serosa heals tightly against the serosa. And mark this down in big, bold letters. The absolute strongest layer of the bowel wall that actually holds your suture is the submucosa. Not the muscle, not the serosa, the submucosa. Also, if the bowel lumen you're working with is too narrow, we make a longitudinal cut called a cheatal split to widen it out.
So I'm going to leave you with a provocative question to really test your surgical problem-solving skills today. If the submucosa is what provides all the strength, why is that cheatal split specifically placed on the antimesenteric border of the bowel during an end-to-end anastomosis? Think carefully about where the blood vessels enter the bowel wall. I hope this masterclass made all these surgical concepts crystal clear for you. Revision Carte Rejo, keep studying hard, and I'll catch you in the next one.